So I'm going to start with Dr. Cosentino. You have comments from about the section? Go ahead.
Yeah. Talking about regarding corneal cross-linking, I think to add to deliver oxygen of the cornea is a very good topic. In fact, we are performing smaller areas for perform corneal cross-linking with very good results. Only at the most deep part of the keratoconus, and we are obtaining very good results with more than 1 year of follow-up. I want to ask something to Dr. Seiler. Dr. Seiler, oh, it's gone. Okay. Maybe it's a good question if we have to deliver the same quantity of oxygen in every case, or depending on the type of the keratoconus stage. And maybe it's a very good question if we have a specific nomogram to deliver the oxygen. It's a good question that I am doing by myself.
Yeah, maybe Dr. Mehta wants to jump in.
So we did some of the studies using high fluence oxygen in Singapore on non-sighted eyes, and Theo mentioned that. So we used, in that study, we used the same percentage of oxygen, 99%. There's a special mask that you put on the eye when you apply the oxygen itself. So we use it as a standard thing, and as Professor Seiler said, you do get quite a marked demarcation line. These were all, I have to say, epi-off procedures, though, in that study. I mean, it should be published soon with a video, but that was using a high fluence flow oxygen situation.
Is it high fluence with all the same type of?
Same type, yeah.
Okay.
So, Dr. Mehta, if you have some comments.
I mean, I think it was an excellent session. I mean, there was some interesting talks on AI modeling by BJ and Stephen Kleiss. Well, I think that you can see where we're going with this, with the AI, where you're getting masses of data. And obviously, AI allows us to analyze this data and basically looking at deep learning. One of the things, I don't know if BJ's still here, is racial differences are going to come out as a difference. And I can tell you that we're looking at sort of AI modeling for looking at refractive outcomes following SMILE. And interestingly, differences in racial groups has an effect. So in Singapore, for example, we have a lot of Chinese, so obviously a high Chinese population. We do see less keratoconics compared to, say, Indian and Malay population as well, and certainly compared to what I used to see in the UK. And I wonder, in BJ's nomograms and stuff, are we looking at racial groups in there as well? BJ, you want to add a comment on that?
Oh.
You can borrow the microphone.
He says we're not. I could read his lips.
Have worked together for so long, you can read his mind.
But what I can comment on that as well is we're actually looking at the corneal biomechanics as a function of race at Ohio State. I don't have anything to report right now, but I think in places like Singapore and Hong Kong, where you actually have enough of a population in your refractive surgery base of different races, you can actually do those kinds of comparisons. And in the United States, I think it's hard to find places where you have large enough populations of the different races to do, in a refractive surgery population, to do those kinds of comparisons. And we actually are finding some differences, and certainly if you're using AI to look at differences in outcomes in SMILE, what would you attribute that to other than a corneal biomechanical response? And if I could actually comment on BJ's talk, I think what you showed with exactly, in your theoretical work, with exactly the same tissue removal, but one stiff and one soft, having such a different response, I think perfectly explains the age nomogram. And I think what people have attempted to do in the past is explain it with young people versus old people, where young have softer corneas and require more treatment, and people have thought because younger people are more aggressive healers, and that's potentially why you should have to do more. But if that's the case, you would have the same nomogram in myopia and hyperopia, and they're opposite. They're opposite. And the only thing that explains that is what you showed in terms of the difference in biomechanical response to refractive surgery as a function of the properties of the cornea. So I think that's a pretty important contribution for that. And then the other comment I wanted to make, Marconi, on your presentation, you looked at optical zone and the impact that might have. And I would like to encourage you to look at ablation zone, because the cornea doesn't know where the optical zone starts and the transition zone starts. The cornea only knows where you've removed tissue. So I think by looking at the optical zone, you're missing the transition zone, which has been certainly shown in multiple studies to not be neutral, because you can influence the outcome by changing the transition zone. And actually, that was dramatically shown by Bosch and Lomb when they went from their conventional ablation to their wavefront-guided ablation in the FDA studies, so the data exist. And they changed two things at the same time, which was a mistake. They changed from their conventional optical zone to a wavefront-guided optical zone, and because with their conventional treatment, they were accused at that time of being too deep, they changed the transition zone at the same time, and their wavefront-guided treatments were not as good as their conventional treatments. And I would say that's because they changed the transition zone and has nothing to do with what was inside of the optical zone. So I would encourage you to look at the whole ablation zone as opposed to just the optical zone and how that relates to your outcomes.
Yeah, I fully agree. That is also part of our research in the future. We are already doing that, trying to add more information, and one main part of that is adding the transition zone as part of how it works as part of the risk factor, and how it's I think we will add a little bit more to what we already have, adding information about the transition zone. But yes, I agree with you. It's a very important point.
And I think your work in terms of volume is important. Paulo Vinciguerra, I don't know if he's still here, actually has a paper published where he showed that with his PTK, he had very thin corneas, ultra-thin corneas with 8 years of follow-up and no ectasia, because it was a very uniform distribution. So I would propose that ectasia is not one-dimensional residual stromal bed, but you have to look at actually the entire three-dimensional response.
Yeah.
And following that exact last statement of the entire three-dimensional picture, I think that we're trying to sort of separate things into what is more important in screening, and I think it's more complex of a process that involves too many variables to be, applicable to one screening technique or looking at one part of the cornea. I think that, in my opinion, the inherent process is a biomechanical process, be it a vulnerable cornea, a healthy but vulnerable cornea, or a pre-existing affected or diseased cornea with form fruus keratoconus. And I think that if we look at screening as the way of earliest detection, we need to try to first figure out what is the earliest thing that happens and then direct all of our forces to look into that. And I think that's why biomechanical studies are so relevant to this, and hopefully their potential extrapolation into a clinical setting in a more practical and efficient manner.
And if I could add to that, certainly Brad Randleman showed us one of the risk factors is age, and younger corneas are softer corneas, weaker corneas, and so BJ actually showed us what the result of that would be.
And I think epithelial maps are a very good tool also to complement the earlier diagnosis.
And I think the key term there is complement, that,
Right.
that they all work together, and I
Exactly.
think that's the point that she was making, that
Right.
you have to do a more complicated analysis.
Right, and it's almost like a chain of events. There's a biomechanical change that then translate into topographic changes, but we cannot assume that the same biomechanical change in different corneas is going to translate in an early response in terms of wear, in terms of the anterior cornea, the posterior cornea, and I think that if we try to individualize each patient, we're going to be chasing our tails instead of going to the root of the problem, and I think that's where the golden ticket is for screening.
Dr. Izquierdo?
Yes, basically a comment for Dr. Malit. We have experience with it's called a new lens 8 years ago, and this lens was a accommodative lens, and basically the concept was also movement on the anterior surface, okay? And our biggest problem was not that accommodation, because we get accommodation of 10 diopter, even bigger, but even larger, but we induce a lot of internal aberrations, like coma, and also was a delayed response of the patient in order when to see at distance and also to near. So the concept is not new, have many years, but until now, I don't know.
Yeah. So I guess I get the last comment before everyone has to go. Really quick, that's absolutely true. And there's a whole issue of latency. Sort of that stimulus between seeing a near object, then trying to change, and then getting a fluid movement. Then you have and so those feedback circles are really important, particularly as you deal with older individuals who've lost the ability to accommodate, and so they're losing a lot of their cues. Getting them back to that, that the whole stimulus, accommodate, getting to the latency is another problem that goes well beyond just getting the optics to shift.
Yes,
Absolutely.
And the internal force are not the same 360 degrees, especially in older people.
Yep.
That's something else.
Exactly. So
Before we finish, just one quick question. I have one quick question to Dr. Huang about the PSD. So what's the current role of PSD in the epithelial map as a screening for keratoconus? Because I would like to hear. I think it's a very important tool, as I have read in your papers. I would like to hear a little bit more, just one more minute about this, because I think it's a very important subject.
Yeah, a few years ago, we published a parameter called pattern standard deviation, where you look at the deviation of the epithelial map from the normal distribution and calculate a root mean square, basically. And we found that it was very sensitive at picking up all types of epithelial deformation, whether it's
Still not available in the
keratoconus
device?
or warpage, and it's still not available. I think it's due to the work that you have to do to get FDA approval in terms of clinical studies, but I'm hoping that it will become available, and it will be synergistic to the diagnostic system I talked about, which is can distinguish different types of conditions.
Because in your perception, it's one of the most powerful tools you have from the epithelial map. Right? That's what I
Yeah, it's almost 100% sensitivity in detecting all kind of deformation, irregularity, and yeah, I do hope it become available soon. Thank you.
Thank you very much.
Marconi, if you allow me one last comment, sorry. I have two last comments, very short. I wanted to point out something you said in your lecture that I thought was wonderful, that all machines should pop in red, that you said requires human inspection. We keep trying to have a machine that pops an answer, like, okay, do surgery, don't do surgery, do this, do that. But we forget that the art of being a doctor and what we have trained for is to critically analyze data and make an informed decision, but ultimately it's our decision. And all of these things require human inspection. And my second comment was to thank everybody that is here right now for considering our thoughts relevant and staying throughout our discussion.
And I think that's a great way to close. Enjoy your lunch. We'll see you back here at 12:45.